Welcome to today's Explainer. We're jumping right into the clinical essentials of influenza. We'll be breaking down this acute, highly contagious respiratory illness from the ground up. Whether you're looking to sharpen your clinical acumen or just want a really solid, structured understanding of how this pathogen operates, well, you're in exactly the right place.
Let's take a quick look at our agenda for today. We're going to meet the orthomyxovirus, look at the clinical picture, investigate the infection, cover treatment and management, and wrap up with prevention strategies.
All right, Section 1. Meet the orthomyxovirus, where we'll cover etiology and virology.
So we're dealing with a pretty formidable pathogen here. Influenza is defined as an acute, highly contagious respiratory illness caused by the orthomyxovirus. And, it primarily spreads through the air via respiratory droplets. But, and this is absolutely crucial, don't forget about fomites. This virus can literally just hang out on surfaces like door handles, countertops, or even your stethoscope, just waiting for its next host.
Now, the actual threat level, that depends entirely on the type. Type A is our heavy hitter. It's the one responsible for really severe illnesses and those massive global pandemics like H1N1 or H3N2. It manages this by using antigenic shift, which is a major genetic change, and antigenic drift. Basically, think of drift as the virus just changing its disguise, while a shift, that's the virus becoming a completely new person, catching our immune systems totally off guard. Then we have type B, which is milder and drives your standard seasonal outbreaks through those minor antigenic drifts. And finally, type C. It's the mildest, pretty rare, and remains virologically stable.
Moving right along to Section 2, the clinical picture. Let's look at recognizing the presentation. If there's one thing to remember here, it's this: abrupt onset. This is your most crucial diagnostic clue. Unlike a common cold that kind of just gradually builds up, starting with a little tickle in your throat, influenza hits you like a freight train. Seriously, patients can often tell you the exact hour they started feeling sick. That dramatic, sudden start, that's your first major red flag.
And when it hits, the systemic symptoms absolutely dominate the respiratory ones right out of the gate. You're going to see a high fever. We're talking 38.5 degrees Celsius or higher. Plus severe myalgia, a pounding frontal headache, and extreme malaise or prostration where the patient literally just cannot get out of bed. On the respiratory side, you can expect a dry, non-productive cough. Oh, and a quick aside, keep a really close eye on your pediatric patients. Unlike adults, kids will frequently present with GI issues like vomiting and diarrhea.
Understanding this timeline is so key for managing patient expectations. You've got that abrupt onset of systemic symptoms and fever on day 1. Usually the fever resolves around day 3 to day 5. But take a look at that long tail. That dry cough and severe malaise, those can linger for more than 2 weeks. Communicating this upfront really prevents patients from panicking when they still feel totally drained long after their fever has broken.
Okay, on to Section 3, investigating the infection. It's time to crack the case.
So, how do we confidently confirm an influenza infection during a seasonal outbreak? Well, during a known seasonal spike, a clinical diagnosis based on those abrupt systemic symptoms we just talked about is super common and honestly, often sufficient. But we frequently need objective testing to guide specific therapies, maybe isolate patients in a hospital setting, or to rule out other pathogens.
For that, we generally rely on 2 main diagnostic tools. First up, RT-PCR. This is your gold standard. It boasts incredible accuracy and can pinpoint the exact viral type and subtype. Then, we have the rapid antigen test. It's super fast, so naturally, clinics love it. And a positive result is highly specific. If it's positive, yeah, they have the flu for sure. But here is the massive clinical catch. A negative result absolutely does not exclude the flu.
Why? Because the rapid antigen test has a notoriously low sensitivity. We're talking just 30 to 50%. I mean, think about it. Flipping a coin gives you roughly the same odds as getting a false negative here. So if your patient has those classic clinical signs of influenza, but happens to test negative on a rapid test, you must still treat them clinically as if they have the flu. Never let a negative rapid test override your clinical judgment.
Now, what about imaging? Well, a chest x-ray isn't standard for uncomplicated cases, but it becomes absolutely vital if you suspect dangerous complications. You see, the flu virus damages the respiratory epithelium, which basically rolls out the red carpet for opportunistic bacteria. If a patient's condition starts worsening, you need that x-ray right away to look for primary viral pneumonia, or even worse, a secondary bacterial pneumonia caused by bugs like strep pneumonia or Staph aureus.
That brings us to Section 4, treatment and management. Let's talk about striking back.
Comprehensive management really requires a strict step-by-step approach here. Step 1 is straightforward, supportive care. We're talking rest, aggressive hydration, and antipyretics. Step 2 is an immediate risk assessment. Is this patient high risk? If the answer is yes, you jump straight to step 3, which is initiating antiviral therapy. But remember, you are totally on the clock. Antivirals really need to be started within 48 hours of symptom onset for maximum efficacy. Before you prescribe anything, though, remember this absolutely massive clinical pearl. When giving antipyretics, you must never give aspirin to pediatric patients. Giving aspirin to a kid with the flu carries a life-threatening risk of Ray's syndrome, which can trigger acute encephalopathy and severe liver damage. Just make it a rule of thumb. Always stick to acetaminophen or ibuprofen for kids.
So who exactly gets those targeted antivirals? Well, if your patient falls into a high-risk category, you've got to consider intervention immediately. We're talking about hospitalized patients, the elderly, pregnant women, immunocompromised individuals, or anyone dealing with underlying comorbidities. Because for these groups, the flu isn't just a minor inconvenience. It can be severe, and sometimes even fatal.
When you do need to use antivirals, here's a look at your pharmacological arsenal. First-line therapy is oseltamivir, commonly known as Tamiflu, given orally twice daily for 5 days. If you're dealing with an oseltamivir-resistant strain, you'll want to pivot to inhaled zanamivir. And for healthy, uncomplicated cases, you have the convenience of Baloxavir marboxil. It's a CAP endonuclease inhibitor that works beautifully as just a single dose.
Finally, we've arrived at Section 5, Prevention Strategies, the best defense.
The absolute golden rule of influenza management is proactive prevention. Annual vaccination, whether you're using the inactivated shot or the live attenuated version, is recommended for practically everyone 6 months of age and older. Remember that constant antigenic drift we discussed earlier? That's exactly why last year's immunity simply won't fully protect you against this year's strain. We have to keep updating our defenses.
Which brings us to a fascinating and, maybe slightly unsettling challenge. As long as this orthomyxovirus constantly mutates through drift and periodically rewrites its entire genome through a shift, the race between viral evolution and medical science is never truly going to end. It forces us to ask, despite our best clinical algorithms and our annual vaccines, are we truly prepared for its next major evolutionary leap? Thank you so much for joining me for this explainer, and keep that question in the back of your mind as we gear up for the next flu season.